A quick note that we are in the holiday season, and so the impact of end-of-life care can be profound and felt more at this time of year. And this is part of the reason why we wanted to have this conversation now and to address this topic. Our goal here is to have a conversation that will allow you to share openly about an uncomfortable topic, end of life and death, which gets very little attention, especially in the United States. Most other places in the world are better at dealing with end-of-life care and with death. But in the United States, there's been some issues, and we'll talk a little bit about that history and kind of introduce what the baseline looks like. But we're really setting up a comfortable space for people to ask questions, for Susan Desmarais, our guest, an end-of-life doula, to be able to talk openly about some of the issues that she has experienced and faced with patients and their families. So that's really our goal today. If we have time at the end of the session, we'll definitely address those questions. Please leave them in the chat. I will be monitoring the chat, but we also have other folks at Gryt who will be taking a look and who can send me messages and make sure that I get to those questions. Please also keep in mind this is a very sensitive subject. People have had drastically different experiences with this, and please keep your questions reasonable, and we'll try to handle them as we can. We may not be able to handle specifics, so we may have to generalize your question, but we'll try to address everything we hear. We ask for your empathy and compassion in talking about this as we approach these difficult topics, and we thank you ahead of time for your patience and your understanding and compassion. We also have a list of resources that are available on the website. We'll talk a little bit about those as we get to them. So several books that we think we would recommend that will help people kind of start to address these topics and start to have these important conversations. Before we kind of get and open the session, I would love to hear more about where all you are coming from. So we're going to drop a poll question here. We want to know what your connection to end-of-life care is. Are you a patient? Are you a caregiver? Are you a family friend? We have a third of you, or just over a third, are family and friends of loved ones who've passed away. We do have a few medical professionals and several patients and a number of caregivers and several who are just interested in kind of understanding more about this topic and preparing themselves. So this is great. We're hoping for kind of a nice mix of people, so we should be ready for a great conversation. I'm realizing that I forgot to introduce myself, so I'm going to do that really quick, and then I'll pass it over to Susan. So my name is Dan Platt. I'm Gryt's Chief Medical Officer. I have a background as a physician, and have, through that background, have been very familiar with death and with dying and end-of-life care, how it happens in this country, and potentially how it should happen, and what the different pictures are. I'm joined today by Susan Desmarais, who has an even better understanding of these issues than I do. Susan is an end-of-life doula. And Susan, please introduce yourself and tell people a little about yourself.
Thank you, Dan. I am a retired mental health counselor. And after retirement, which I proved not to be very good at, I became a hospice bereavement counselor. And then got my end-of-life doula certification in 2020. I had enrolled for that certification right before the pandemic hit. So I started the pandemic by studying end-of-life doula. But, and I come to this work after a lifetime with a lot of losses, which I think a lot of us have in common, even if it doesn't get talked about. And loss doesn't necessarily prepare you for the next one. In fact, losses tend to build upon other losses, and grief sort of gets refreshed every time a new loss comes along. In my work at hospice, I very quickly began to feel like that was the work I was born to do. It felt like that's exactly why I was put here when I was put here. And I was lucky in that I live in a small rural community. I actually live on an island. And the hospice that we have here was very unique. It was not Medicare funded. It was privately funded by donations but we never charged patients or their caregivers anything. It was all, nobody paid anything, not for medication, not for anything. And as such, we were able to work in a way where we could give patients whatever they needed. And if they needed a bereavement counselor for 5 hours, they got it. And that was such a privilege. And I had many life-changing experiences in that. And through that, became really dedicated to helping people give voice to what they want, what they fear, what they need as they're facing the end of life. And this doesn't necessarily mean, in the last few days or weeks of life. It means beforehand. And so that's a passion of mine that it's really about empowering people and encouraging people to listen to their fears and connect with their courage, and with an open heart, try to move forward. And that's really it.
Susan, so well put. Listen to their fears and act with courage is kind of really what this is about at end of life care. I would love to kind of level set things and talk a little bit about where we used to be in this country in terms of death and how we dealt with death culturally, and where we are now, and kind of where I've seen personally where we've ended up and what we have to do. And then I'll pass it over to Susan to kind of talk a little bit about what it should look like and hopefully how we can change where we currently are. So if you think about back in 1900, let's say, almost everyone died at home, and they died with their family physician who had known them all their life. They died with their clergyman who had known them all their life, and they had support. They had someone, they had both their family there, but they also had people who knew them who could offer medical support and guidance, as well as spiritual support. And this was kind of the way things happened. From there, though, we moved into a period of time now where we've medicalized death. We've turned it into something that happens away from the home, that happens in hospitals. So 40 to 50% of people at this point die in hospitals. Might be a little bit less than that today, but it's high. This country, we speak about people in biomedical language. We talk about disease in the hospital. We don't talk about illness. And the difference is that a disease is the thing you die of. A disease is congestive heart failure, is cancer. Illness is a patient's personal experience. Illness is the subjective experience you have, and it includes things like fear, anxiety, pain, loss of identity. It addresses these psychosocial issues that come up when someone is dealing with the end of their life. And really, if you kind of think about where this comes from our cultural identity. In other places in the world, death is something that people address very early because more people die at home in other places. If you think about, say, in Eastern cultures, there's both the idea of rebirth. So if you think about Buddha, there's Buddhism that leads to the idea of reincarnation. Same with Hinduism. Also, if you think about places like China, there's something called filial piety, which is people really respect the old and they care for them very carefully. They bring them into their home once they're too old to care for themselves and take care of them. So if you're a child in China, you've often seen a grandparent or loved one pass away and been there for that. And you've dealt with those emotions and you've learned and kind of been through the practice of passing someone onto the other side, so to speak. Here, the words I just used, we really use euphemisms for death. Pass away. We don't say death. We don't say, we say things like they've gone to a better place in an attempt to explain. And it's mostly because we want to keep ourselves distant from it in the United States. And this is something that's kind of been typicalized in Western culture, but also through our medical experience. We have, if you're in a hospital and you're dying, you're hooked up to machines. There's a lack of physical touch. Especially once the physician knows that the end is near, they tend not to drop by and see those patients as often as they should. They tend to spend their time with patients that they're trying to quote unquote save, and not helping people transition and helping families transition especially. So the need is so high, the need is so acute, and there are so many ways to do this better. Susan, I want to bring you into the conversation at this point to talk a little bit about what hospice does and how can we make this better? What can we do to really help people along the way?
Well, I think that a lot of it comes down to asking questions as a patient, as a caregiver, wanting to know about hospice, wanting to know about palliative care. And there are some medical professionals who resist talking about hospice or palliative care to people. I think that unfortunately, some healthcare providers are trained that having a patient die is a failure, and actually helping a patient live well until their death is a success. And that's basically what hospice does. The hospice that I have worked with, our motto was, we help people live until they die. And part of that is encouraging conversations between people. A lot of people really want to die at home. And some were afraid to say so because they don't want to put stress on their family, particularly in the case of a parent who is dying. It's like, oh, my kids have enough on their plate. I don't want them to worry about that. I don't want to be a financial burden, all of which are very realistic concerns. And again, it circles back to the communication and talking about it. And sometimes it's as simple as saying, well, okay, Mom, but why? Tell me why. And then trying to be comfortable with the pause. We tend to, as human beings, we tend to ask a question and then jump in to try and get the answer. And sometimes you need to just let why land and have its space so it can be answered. Hospices around the country and around the world offer different things in different places. So there's no one set of guidelines or rules or anything like that. But for the most part, hospice is about comfort, be that medical comfort with medications to keep people pain-free, maybe to keep, oftentimes when people are terminally ill, they have anxiety and sleeplessness. Sometimes caregivers do. And there's absolutely no shame in asking for help in that arena if you need it, and speaking to someone from hospice about that. And hospice can facilitate that with doctors. Hospice nurses are on call 24/7. That's universal. Hospice will normally provide a hospital bed and equipment that is needed for someone to be at home, whether that's intravenous equipment or, monitors, whatever. Whether how that's paid for differs hospice to hospice, state to state, country to country, unfortunately, and can be determined by insurance companies. And hospice services are a nurse. Usually there are a number of volunteer staff with hospices. Very often they are people who have had a loved one die in hospice care. So these are really people who sort of know their stuff, have been in the trenches, and they are there to provide a shoulder, make a meal, whatever. And I think more people are getting more comfortable with hospice and think of it as less than a bad sentence. It doesn't help that Medicare, you have to have less than 6 months to live, and you have to have 2 doctors say that in order to get hospice benefits through Medicare. I don't think that helps people mentally, but I'm also here to tell you that once in a while people get discharged from hospice by living. So I don't know if that covers what you were wondering, Dan, or?
Yeah, it does, Susan. I wonder for those who don't know, kind of what's the difference between what you might experience in end of life in a hospital setting, an ICU, and what you might experience in a hospice, and both I think you talked about it, but I'd love to emphasize kind of what the difference is between hospice at an independent location and hospice at the home care. Do you think let's talk about those for a little bit, because I think that'll really clarify things for people.
Okay. Hospice in a facility would usually mean in a hospital of some kind. I know the rural hospital where I live, they have a room that is dedicated. It's on the regular hospital floor, but it's way away from the nurse's station, and it's dedicated for hospice care when it's needed. There are some places, and I think there are probably more of them in Europe than there are in the United States, that are actually, they're like bed and breakfasts that are for hospice patients. And then there's, end of life care in a hospital. Typically, end of life care in a hospital is what you experience with regular care when you're in a hospital. It's the same model. It's how it works. And with hospice care, if someone's in the hospital under hospice care, the hospice nurse is the person who is in control. And hospice can bring in volunteers. Family members are typically allowed to visit anytime, all the time, however long they want to stay. There are no drastic measures taken. And most hospitals that have a hospice room will allow for a lot of privacy and quiet time for the family and for the person. Hospice care at home is generally, we bring in a bed for people. Usually intravenous is connected to the patient because if nothing else, that's the best method for delivering pain control. I would defy you to find anybody in this world better at pain control than a hospice nurse. A dedicated hospice nurse really knows what they're doing on that and is able to manage medications so that, especially as a person gets more towards the end, there are periods of lucidity and being able to communicate. And that's really important, because the last sense to go for a person who's actively dying is hearing. And, so they can hear, people can hear, your loved one can hear what you're saying. And if there seems to be agitation in the person that doesn't have a physical cause, and that's something, again, the hospice nurse can decipher. Sometimes allowing the pain medication to lift just a little bit will allow a person to communicate if they want to. And so I think the biggest difference is the ability to meet individual needs and not have to fit into another model. And also, when a person dies at home, if there are any things that the person specifically wants, be it flowers, candles, music, a beloved pet, they can have it. They can have that. And that's really important. And I will mention that there's something in the resource list called 5 Wishes. That is a document that is a legal document in many states. And it's a wonderful way to open a conversation. 5wishes.org will send out free copies of that. And it's more than a healthcare proxy, in that it's not, do you want extreme measures? Do you want that? It's, do you want flowers? Do you want food? Do you want to be warm? Do you want to be cool? And it's really a fabulous tool for opening a conversation too, especially when nobody wants to go there, which is usually what happens. But, it's personal preference, but, I think that the home death is really it can be very special. And there can be a lot of connections that happen during a home death that might not otherwise happen.
Yeah, absolutely, Susan. Having seen how death happens in the hospital, it's something. I mentioned the medicalization of death, but it really is that. It's people die hooked up to machines. They die on respirators. They die not being able to communicate with their loved one. They die uncomfortable. They die with physicians who are constantly coming in and out of the room, whose names they don't know. Just the nature of a hospital setting, there's a rotation of physicians, a rotation of nurses. So you have so many people around this person, which is confusing. I think, the word that you mentioned that I most associate with hospice is comfort. It's giving people a comfortable way, a way to be able to communicate, I think, to talk about what they're hoping for, what their experiences with their loved one. I would love to know more about, I think a common misconception of hospice is that you're putting someone in a position where they're just waiting to die. And I want to emphasize that is not the case. But Susan, I was hoping you could address that misconception about hospice and what will you mean by end of life care, as opposed to something like resuscitating people in the hospital or intubating them.
Sure. Actually, I would propose to people that in hospice care, people probably, and I think there's a statistic out there, but I'm not a statistic person. So, but that people actually live longer in hospice care, oftentimes outlive what their projected time is. And, it's things like being able to go outside, being able to be transported to a chair to watch grandchildren play outside, to watch one's children play outside, to have your loved one be able to get into bed with you and hug you. And, there are points in many diseases when some of these things cannot happen. But in hospice care, if somebody wants to, be driven down to their favorite spot, to watch a sunset or something, they can. It's just, okay, let's figure out a way to do it. And hospice usually will figure out a way to do that. I could go on for hours with stories about some of the amazing things that we got done for people in hospice, and favorite meals can be cooked. I had one patient in hospice who wasn't supposed to have a glass of wine, and when she found out she wasn't getting any more treatment, she started having a glass of wine every night with her husband. And she would toast it and say, well, if I keep drinking, I've got to keep living so that I outlast the number of glasses of wine I'm allowed to have. So I think it really is, again, about giving people what they need. But before you can give them what they need, you have to listen to what they need. What do you want? What do you need? And then try and filter out. And this is where a hospice counselor can be very helpful. What's doable and what's not? Because you're going to come up against those things where wants or needs aren't doable. So if we can't do this, can we do this? Can we figure that out? And there are some I noticed there was a question in the chat about how do I maintain my own well-being in this? And the gifts of being allowed to connect with people at these times and at this level so far outweigh any costs. And in terms of self-care, usually people who work at hospice are really good about supporting each other. And And it also really taught me at the very beginning that I had to really kind of get my stuff together and figure out, what do I need to do for myself on a regular basis to do this work? Because doing the work mattered and matters so much to me that I will figure out a way to sustain myself to do that. For me, it's bike rides. I ride my bicycle year round in the woods. So.
Thank you, Susan. Something else I'd love to emphasize is the fact that people do receive care in hospice, but the care they receive is about comfort. So it's about pain and managing pain. It's about, making sure that people are coached enough to have those conversations at the end of life that we hope they have. So if that's taking people off benzodiazepines or medication that's making them foggy, it's a chance to do that. It's a chance to make people comfortable. And what hospice and palliative care physicians really specialize in is comfort, is making people, giving them the ability to do the things you said, Susan, to go see a sunset, to have a glass of wine, to make it to an important life event if they can, to make it to a wedding before they pass away. I've had so many patients who they want to live for this major life event, for their son or daughter's wedding, for seeing their grandchildren get baptized, whatever it may be. And I think that can be a source of relief for the family to be able to talk about it. So I really, as a physician, I commend so much what you do, Susan, because, what I see in medical school, what I've seen hasn't prepared me to, if you look at textbooks, I was pulling out, I have a gigantic cancer textbook over here that's 2,400 pages long. There are 10 pages on end-of-life care and on communicating with patients. In that, that is kind of where you're set up in medicine. And so, so many doctors are uncomfortable with these situations and need to turn to people like you, Susan, who have this experience. So I'm wondering, how do people go about getting hospice services? And what has been your experience in terms of when people are able to access it? And, just how, if you're in a hospital, how do you go about making sure your loved one gets this care?
Well, I would say, I'm sorry we keep circling back to communication and listening, but that's really what it comes down to. And sometimes healthcare providers are waiting for a family to say, well, what about palliative care and hospice? What about that? And in most places, people can receive palliative care without being admitted to hospice. And palliative care is all about quality of life and trying to keep people moving and doing as much as they can do without exacerbating pain, discomfort, that sort of thing. And people can, if they have a diagnosis or a loved one has a diagnosis that makes them think they're going to need hospice care at some point or want hospice care, you can call the local hospice and say, hey, can I talk to somebody? And you can make an appointment and go in and talk to them and say, we're not there yet, but we're going to be there. And, one of the things that I've learned through life and through my work is that none of us, no matter what we're trained to do, no matter how well we're trained, are at our best when we are reacting in some sort of emergency situation. And so if we can manage to have those conversations that are emotional and difficult to begin with, when we are not in a reactionary place, that can be really, really helpful. So that you kind of know the lay of the land and what to expect. And I think that is really, really important to do. And working as a hospice counselor, one of our biggest jobs is to facilitate discussions and to ensure that we have time alone with the caregivers and with the patient so that if there's something that needs to be conveyed, sometimes people are more comfortable saying it, say, to me than to their daughter or their partner. And, and then I can either convey it or I can facilitate a discussion. And so, that's sort of where we need to go with that. And hospice isn't, in some places, hospitals and medical care are one size fits all. Hospice is not one size fits all. It's we fit the care to you rather than you being fitted to the care.
Thank you, Susan. I think I can't agree with you more. It's really about fitting care to what people need. We've gotten a few questions in the chat. I think so. Here asks, can you please talk about the difference between palliative care and hospice? And you started to address this a little bit, Susan, that you can get palliative care without being in hospice.
Yep.
But if you're in hospice, you are going to be receiving what is called palliative care. And that's really that's comfort care is a synonym for it. That's about getting the pain meds that you need, but, removing treatments that are meant to prolong life.
Correct.
So you're not going to be getting chemotherapy in hospice. It's palliative care. You're not going to likely be getting, EKG monitoring, or, if you're in an arrhythmia. For comfort, we may shock you out of it, but not to, it's not to prolong life. It's meant to make people comfortable.
Exactly. Yep. Yeah.
And then there's a question from Sharon. Can you address your work as an end-of-life doula and how that fits into hospice?
Okay, so as an end-of-life doula, the role is more as someone who's not being reimbursed by hospice or anything like that. I'm there as an advocate and as to be present in ways that take a load off the family, I guess is the best way to describe it. So typically as an end-of-life doula, it's very similar to a birth doula, only in the reverse. And as an end-of-life doula, I meet with the family and we talk about what are the central things they want and don't want. I always ask that question, what do you want? What do you don't want? What do you fear? What are you comfortable with? And it's my job to see that the family gets those things. It's my job to be the person that if they're not happy with something that's happening, they tell me and I take care of it. It's also my job that if they want fresh flowers every day and nobody in the family has time to go to the florist, I go to the florist. So it's really a very supportive role instead of having any directive part of it, is I guess the best way to describe that.
Thank you, Susan. Yeah, I think it's really, when someone is in hospice, there's a care team around them, right? There's an end-of-life, there's a doula such as yourself to facilitate conversations. There are nurses, there are physicians. I think people often, if you're at home in hospice, these people are coming to you.
Yep.
So you are receiving the best possible care. It's a way to, I think of hospice as a way for everyone to get comfortable with the idea of death, which is something that we don't have in this culture. We've pushed it away. We've professionalized it. We put people in charge when our loved one dies. A mortician and a funeral home, we go seek other people out. In other cultures, they don't do that. In other cultures, the tradition is to, for instance, to clean the body and to have loved ones do that. And there's a whole ritual around death that we simply don't have. And so I think of hospice as part of, it's trying to create a ritual that the United States and other westernized countries can use in order to make it something that's normal, and in order to, death is a natural part of life. And I think we sometimes forget that in our attempts to prolong life no matter what.
Yeah.
I'd love to talk to you, Susan, you've been mentioning communication as something so important. I would love to talk about the caregiver and their loved one who's preparing for death, how they can communicate. I think this is a really difficult conversation because people aren't prepared for it in our culture ahead of time. How do you facilitate those conversations? And what do you hope that people are getting out of it on the caregiver side and on the patient side?
That's a biggie. That's really a biggie. What I find happens the most when people hold back on communication, particularly in hospice care, is that they don't want to hurt others. And there are people who either have done wrong or who have done perceived wrongs that want to be forgiven. And that opens up the thing we could do a whole nother podcast on about, forgiveness at the end of life. And it's really a tough one because from what I've seen, people that are very conflicted about possibly having inflicted a lot of pain in their lives have the hardest time going. They tend to take the longest and have the hardest time. The guidance I give to caregivers on that is you need to search your being, your heart, your soul, however you term that, and decide what you are going to be comfortable with after this person dies. Because you're going to live and you don't get a do-over. And that can sound a little bit harsh, but it's also my job to bring reality into this and not to do the, oh, someday you're going to lose your father. Well, someday might be tomorrow. So you can't just keep waiting. And as I mentioned earlier, sometimes I'm a go-between on the conversations. Sometimes I facilitate it. Sometimes I deliver the message. And people hold back for all different reasons. I could share one story that might really illustrate this if you'd like me to, Dan. It's not a long one. It's I had an instance where a woman who was she was under the age of 65 and she was dying of cancer, and she was in hospice care. During the time she was in hospice care, she took a trip to Italy and came back, and she did a road trip with her husband and came back, and she had some really wonderful time, and then the pain got really intense, the physical pain. We had a lot of conversations, and when you're deeply involved with a family like that, you often see the very best and the very worst of people within a 10-minute time span. And that's just the nature of it. It's real, and it can be gritty. But this woman was clinging and hanging on and suffering so badly, and there had been wonderful communications between she and her kids and her spouse, and and we couldn't figure out what is she hanging on to. And she managed the strength to ask me to come into the room alone, and I did. And I actually had to lay on the bed with her for her to speak to me. And she wasn't letting go because of what her death would do to her father. And as a parent, she had a sense of the pain she was going to inflict on her father by dying. And nobody, myself included, had thought of that. But, we were able to have her have a telephone conversation with her father that gave her peace. And she died within 24 hours. And so sometimes it's about that. It's about the presence, and it's about, sometimes I don't know how I do what I do. I just follow my instinct, my intuition, my heart. And I think that when you're looking at end of life, it's also important to remember that for the caregivers, for the survivors, their life is ending too. Someone is having a physical ending, but their life is, as they have always known it, is ending. And there's a lot of grief around that too.
Yeah, Susan, I think the story you bring up is not an uncommon one. When I've been rotating on hospice floors in multiple hospitals, I'm always amazed by the number of people who say, I need my loved one's permission to allow me to die.
Yep.
And it's, I'm always impressed by people being so honest about that and having the courage to bring that up. I think that's something, having those conversations is something that hospice, it does a great job at bridging that gap and making sure that communication happens. There's a question in the chat about how private caregivers who don't really want to bring in help, but need the support or need the help facilitating these conversations at end of life. How do you go about kind of reaching out to those people or making sure that they have access to this type of care? And then I'm curious, and someone who's reticent to have these end of life conversations with their loved one, what can we do to make it easier for them? What suggestions do you have around to build around kind of and either reconcile or reflect? How can we get caregivers and the patient that they're caring for talking to each other?
Well, I'll address first the very private caregivers who don't really want to bring in help, but need the support. Is that's really about sort of planting a seed and being gentle. And sometimes it's about giving information to, oftentimes if you've got a family with multiple family members, someone will be resistant to the idea of bringing someone into a home, bringing a stranger into the home. They think it's going to change the dynamic or, change things drastically and people won't be free to talk or whatever. Well, most people who do palliative care and hospice, another part of our job is to blend into the background until we're needed. Everything we see or hear in a home is confidential unless we are given permission to share it. And so I think that part of it is to say to a very private caregiver, I understand you want and need this time. And by bringing hospice into your home, you won't have less time or privacy with your loved one. In fact, you'll probably have more. And we will not intrude. You can always ask us to leave a room. You can ask us to go for a walk and leave the house. We will do that. And also for people who don't want to bring help into the home, there are caregiver support groups around, and there are now probably more than ever before of them. Some of them are specific to diseases. And I would also say that, you could call your local hospice and say, I'm not ready to have someone come into the home. We're a very private family. I'd like to know what kind of resources there are out there. And there are social service agencies, which, with COVID and everything, they're so very strapped now, so it's difficult. But I would say plant the seed and be kind of gentle with people and see where that goes. And what was the rest, Dan, that you wanted me to talk about?
I think in someone who's having trouble having that end of life conversation with their loved one, what suggestions do you have to start to bridge that gap to make things a little bit more comfortable for them?
I really feel like the probably least defensive, most innocuous way to do it is to use something like the 5 wishes or a movie or a book and say, I just read this book and it made me realize that we've never talked about this. And I'd really like to hear what you think and feel. And if people resist that conversation and you need to have it, if there's a medical thing coming up that it has to be done, oftentimes the thing to do would be to say, well, I'd like you to read this chapter, or would you look at the first 2 pages of this 5 wishes thing and think about it? And then in a couple of days, we'll sit down and talk about it. So you give a kind of a release valve. Physically, if you can, don't sit face to face with the person. Do not stand over a bed. Do not stand over them. Our body perceives that type of physical language as somewhat threatening and not comforting. Sit to the side, sit next to, whatever, to make that more comfortable and give people the space to do that. But sometimes you also need to let them know there's a deadline, to do that. And it's funny because we all have our things. I mean, here I was running around doing 5 wishes with people and counseling at the end of life and so forth and so on. And my family doctor says to me, "Oh, you haven't filled out a healthcare proxy for me." I'm like, "Oh, oops," and so we just, and then when I sat down to fill it out with my spouse, he was like, "No, I don't want to talk about this." Well, we kind of have to. So let's just start the discussion and go from there. So, it happens. We're all human.
Yeah. Susan, I was thinking about this question too, as I was asking it. One of the things that I've seen that can be really useful is just taking a moment to remember specific situations. And like you said, the last sense to go is hearing and physical touch. So I think putting your hand on your loved one's hand, making sure, letting them know you're there through physical touch can be really useful in terms of facilitating it. It's amazing what just that touch can kind of bring out in terms of wanting to offer support, wanting to talk. But I found that thinking about a time, a good moment, and relating that to your loved one can be a chance to open up some of this, to say you're going to miss these moments, but you appreciate all the moments you had. I think that's a really useful way of opening up that conversation as well. I want to talk about, you mentioned healthcare proxies and living wills. It's something that we don't do enough of in this country. I think the last time I checked, I think only 1/3 of people had a living will, or had, by the time they kind of got to this point. What exactly are those, and what's the goal? What's the purpose for someone filling it out? And, I think there's a lot of resistance. Can you kind of talk about overcoming some of that resistance and, maybe kind of explain more to people what this means?
Sure. Well, the living will is a document that dictates what you want, what you don't want at the end of life. It's very specific. It's a legal document, and it appoints a healthcare proxy to carry out your wishes. And one of the things that, we talk about communication and people talking about stuff and then not doing it is that, it's not unheard of to run into people who have filled out healthcare proxies and appointed someone that didn't know they'd been appointed. And they get this call saying, okay, you need to do this. So again, communication, but it is a legal document. And most hospitals and medical practices now insist that one of those be filled out. So most people should have one in their doctor's files. And in most states, you have to have an attorney execute a living will or a healthcare proxy. Not all, but in most. The 5 wishes it is a legal document in some states, and it says right on their website, which I see Jessica put in the chat, which states it's legal in. And that's really more about comfort. And, what do you want do you want to be kept at home? Do you not care whether you're kept at home? One of the things about these documents that when people are resistant is to say to them, I want to know what you want so that I can honor your wishes. And I don't want there to be any family arguments or anything like that. We all need to be together to love you and to grieve you. And the more things we can do to create less tension, the better. So will you please join me in doing this? And oftentimes people who are very resistant to do it for themselves will do it for loved ones. And, when I had to sign the papers to unplug my father from life support, knowing that that's exactly what he wanted and he trusted me to do it, gave me an immeasurable amount of peace. Immeasurable. And I would share that with people and just say, that can be one of your parting gifts, is to leave peace behind for people in knowing that they honored your wishes.
Absolutely. So well said, Susan, and so important to be able to honor people's last wishes, to know them in that way, and then to be able to support them, I think is so important. We have to start wrapping up here, so maybe we have time for one more quick question. I see there was, let's see, Noreen, I think you put in the chat, and maybe we'll answer the question, and Susan, I'll give you some time to kind of for last thoughts around the conversation we've had and things that you would love to mention that maybe we didn't get a chance to talk about. So Noreen says that she has a friend whose father has cancer and they're having trouble having these communications. And we talked a little bit about how they can be facilitated. But are there any recommendations that you have, Susan, on how we can gently encourage and, how you start to facilitate or those conversations? And maybe we can use this as a chance to kind of talk about some of the key points that have come up during this conversation and wrap up as well.
Yeah, to gently encourage conversations around death and dying really is, it's very individual. And I would offer that there's encouraging conversations and there's forcing conversations. And, sometimes, again, it goes back to the seed planting of saying, you said a friend whose father's cancer is back. So, Dad, I really want to honor and give you what you want and need. And I want to talk to you about this and I want to hear you. So, please help me. I love you. Please help me. And we don't have to talk about it right now, but I'm going to ask you again tomorrow. Sometimes that's helpful. Or also, again, going back to that, what we mentioned is some of the books that both you and I have mentioned, Dan. And there's Atul Gawande was just on a PBS show called Tell Me More with Kelly Corrigan, and it's a 1-hour show with just him, and it was fabulous. And he talks about opening those conversations. So to say, I just watched this show, you want to watch it with me, or something like that is also a possibility. And then you've got the side-by-side sitting, not the face-to-face, the side-by-side. And, and maybe a person just says, oh, yeah, that, and then clams right up again, but you've got an opening.
Yeah. Susan, I've found too, one of the helpful things about having someone such as yourself, an end-of-life doula, there is that sometimes people feel more comfortable having these conversations with strangers. Yes. With someone that, they may feel uncomfortable having them with their son or daughter or a close loved one, but they may be much more comfortable at least having them with you, and that can be a way for them to practice.
Exactly.
And I think that can be another very useful thing about hospice. So we only have 2 minutes left, so we're just a few quick notes, and then we'll wrap up. So this video is recorded and will be available. If you could just give us a couple days to make sure that make any edits, and then we'll have it up on the website. Susan, you mentioned some of the resources. We have a resource page with a list of books that you recommend. There are so many in this space, and so many that I think can be helpful. But it's really, again, finding kind of the right one with the right tone. Some people who might have a more scientific bent, there are books that I could recommend that are a little bit more about kind of what actually happens in death. But I think a lot of what people need is a support and the need to have these communications. So you mentioned Atul Gawande. He wrote an excellent book called Being Mortal that I think both of us highly, highly recommend. It's just a fabulous, he does a fabulous job at walking both laypersons and medical people through what to expect and kind of where we were and where we are now and what should be done. And so I highly recommend that. Are there other books, Susan, that you want to recommend before we sign off?
Any of the ones that I mentioned in there about being a doula, those are not just for doulas. They're about starting conversations, and they can very easily be used for tools. And there's another one that I know I didn't put in the resource list, and maybe Eileen or somebody could drop it in. If you're on social media, there is a thread on Facebook you can follow called Cultivating the Doula Heart. And it is a group. She posts probably maybe 2 things a day, but they're quotes about grief, they're quotes about death, and they're absolutely lovely and beautiful. And those could be great conversation starters too. Cultivating a Doula Heart is the name of it on Facebook.
Thank you, Susan. So we'll add that to the resources. I want to thank the audience and thank you, Susan, for being here and having this conversation with us, and for talking about something that is difficult to talk about, but is so important. So thank you to the audience again. Thank you, Susan, for being so open with us. And we'll sign off now, but hope you have a good rest of your day, and hope that this has been a thoughtful way to and hopefully you can take something away from this conversation. And Susan, I'm sure that people have other questions that I'm sure you'd be willing to talk to them. So
Sure.
Please just let us know how we can help. And thank you so much for being here.
Thank you, everybody. Thank you, Dan.